Good evening, everyone. Welcome to HCMA's second COVID-19 virtual town hall meeting. I'm Dr. Michael Cromer, president of the Hillsborough County Medical Association. And it seems like just a few short months ago that we had our first meeting that was a benefit to the providers and members of the association, providing information that's very pertinent in our day-to-day practice and day-to-day lives. Proud to have a good panel again joining us today. Let me introduce, starting in upper left-hand corner of my screen anyway, Dr. Douglas Holt. Dr. Holt's the health officer of Florida Department of Health here in Hillsborough County. Welcome and thanks for joining us again, Doug.
Well, thank you for having us, for having me.
Good. And next we have Kami Kim. She is the chairman of the Infectious Disease Division at USF and is involved in much research of epidemiology, and also sits on the board of the Sanford Guide, which is a book that we all are familiar with. Welcome, Dr. Kim.
Thank you for having me.
Hello, Dr. Sinnott is next, another panel who joined us last session, and John Sinnott is the chief of internal medicine at USF and an epidemiologist. John, welcome. And we have Dr. Charles Lockwood, and Dr. Lockwood, of course, as most of us know, is the USF Senior Vice President and Dean of the USF College of Medicine. Welcome, Dr. Lockwood. Glad you could join us tonight.
Intimidating being on with the three infectious disease docs, but if there are any questions about delivering babies, I'm here. And
okay.
He's the only adult in the room.
Okay, well, let's get started tonight. And what I'd like to do, first of all, is Dr. Sinnott, I'm going to direct this question to you. Just tell us again, enlighten us, extrapolate on anything you spoke about last time, about what is it that sets this coronavirus, COVID-19 virus, apart from the other viruses that cause other endemics. What about the pathophysiology do you think we as clinicians should know about, and maybe some insight into some treatments because of its pathophysiology?
I'll do that in less than a minute, I hope. First, it's a new virus. It clearly made a jump from animals to man in Wuhan, China, in a wet market around December 10th. They had 14 cases of unusual pneumonia with fever during that time period. Since then, it's spread. There's questions whether it's mutated or not, but it's certainly become a global pandemic of great threat. Although it has a low mortality rate, we're completely unaware of what the long-term consequences of infection are. I know with SARS, 17 and a half years ago, we thought people that got better from SARS, a very closely related virus, were better. But 5 years later, a certain percentage were on oxygen, some needed hip replacement, some had an obscure neuromuscular weakness, and a couple had cognitive difficulties. So these coronaviruses can act in very peculiar fashions. For COVID-19, the major route of infection, looking at marmosets, which are an ideal model, seems mostly to be through the nose, through what's called Kesselbach's plexus. And there it gains access to the bloodstream. And then it becomes briefly viremic, and in that time infects the endothelium, producing an endotheliitis. Pathophysiologically, that's the viral phase, and the phase at which we have derangements and thrombosis that cause very serious complications like stroke, heart attack, milder issues like livedo-reticularis, etc. And most people at that time treat those patients with anticoagulants, ranging everywhere from aspirin to Eliquis to low molecular weight heparin. The second stage of the illness, the virus trends down. So around day 8 or day 10, you can't culture the virus anymore. These people are not contagious. But at that point, they start to develop leaky capillaries in the lungs. And there you get the characteristic pulmonary reaction with plate-like atelectasis, decreased PO2. And at that phase where you're going from viral to immune is where many people like to use remdesivir and steroids before things get too far down the track. So far, we've used many different things in our studies. Dr. Lockwood came up with the idea of using antibody-rich plasmas. We've tried that. We have several experimental drugs we're using, but Dr. Kim is the one in charge of that and would know more about that. For the moment, the only true way that we have to protect ourselves is a mask worn over the nose and thorough hand washing.
Is there any role in the use of anticoagulants in these patients?
For me or Kami?
For you?
Or for Sinnott? Yes, I strongly feel after Dr. Kim explained immunothrombosis to me, I said, aha, this is a great idea. So anyone would get with an initial PCR positive goes on aspirin. And if they have serious risk factors, I'll use either Eliquis or Xarelto.
Okay, aspirin in lower symptomatic patients that are positive and high risk, Eliquis or Xarelto.
A 21-year-old, mild symptoms, just aspirin. A 55-year-old with 2 stents and diabetes would get Xarelto or Eliquis at half a dose, not the full dose.
Okay.
So 5 of Xarelto or 2.5 of Eliquis twice a day. And they would continue that for 3 to 4 weeks.
Any other input by any of the panelists on that summary?
Yeah, I mean, so it's fascinating the level of thrombosis, particularly in the pulmonary microvasculature. Part of it is the induction, I think, of tissue factor by the cytokine storm that John was talking about. The virus itself may be inducing tissue factor expression systemically when viremic, or it could be the cytokines, both of which, if the virus binds to toll-like receptors, it can also induce tissue factor. So it's really quite striking that this is such a predominant problem. In pregnancy, it's a big problem because it's a hypercoagulable state. And so we've been recommending an up-to-date anticoagulation for all pregnant women admitted with COVID-19.
Okay. Okay. 2 months ago, we were still, during our last town hall meeting, we were still in the middle of our shutdown here in the county with restaurants and other businesses still closed. And one question that was posed is, what did we think the second wave would look like? Well, whether we're in that wave now or this is just a continuation of the first wave is a matter of debate. But Dr. Holt, I'd like you to comment, particularly here in Hillsborough County, that's your area of influence, level of expertise and knowledge, and compare us, good or bad, or high amount of risk or low amount, compared to some of the areas in the rest of the country and state. Can you do that for us?
Sure. We are still in the first wave. There's no doubt about that. May 1st, May 4th, we were seeing about 50 cases a day, trending down. We had a positivity rate below 5%. 2 weeks later, we were seeing 200 patients a day, or positive cases a day, and our positivity rate was above 10%. We peaked around 700 cases a day, and if you look at that in a cases per 100,000, that's about 45 cases per 100,000. Currently, New York City is about 5 cases per 100,000. So it's phenomenal where we went in such a short period of time, and clearly we were not, the virus had not been suppressed, and combined with some of the rush to get back to normal, the virus just exploded. If you look at Florida as a whole, for the last week, we've had the most cases in the entire country, more than California or any other state. And in fact, Miami is seeing rates that are by far the highest in the country. They're at close to 80 plus per 100,000. We've started to crawl our way back down. We are now closer to, in the upper 30, 40 per 100,000. So the trend is better. We still have a positivity rate north of about 12 to 13%. Compared to Pinellas County, they're in better shape. Their rates and comparisons are about 30 per 100,000, and they've been under 10% for most of this week. So it can be done. It's just going to take us a long time to get back to what was only 6 weeks ago.
How about how are we compared to Houston?
Yeah, Houston is their numbers. When you look at it again per 100,000, are in that around 30. So we're about not quite. What is, I don't know the exact percentage, but we are worse off than they are by significant amounts.
Okay. Dr. Kim, a lot of your work is done in research, but also in the clinical setting.
Yes.
There was a lot of questions we got surrounding the whole issue of tests. I was wondering if you could just take us 101 through the tests that are available, what's different between them, what are their roles clinically or experimentally, and why such long time for a turnaround? Anything you want to talk about test, if you could.
Okay. All right. So testing is very confusing, particularly for a new virus, right? And so when you have a test, you want one that's sensitive. In other words, picks up all of whatever you're trying to measure and is specific. So won't, so if you had a test that picked up all the COVID, but would also label anyone who'd had a regular common cold this season, then that wouldn't be a very useful test. So this is why there's a lot of arguments about the types of tests and things like that, because there's a lot of things that we don't know about how good the tests are, and that's why you hear different things as more knowledge accumulates. So this is an RNA virus, and the most sensitive way of detecting this kind of a virus, which infects the respiratory tract, so Dr. Sinnott said, goes through the nose, is to do a nasopharyngeal sampling of the cells that are in the back, way back in that nasal passage. And the most sensitive test is what's called a Pcr test. So that detects the genetic material in the virus, in other words, the RNA. And that's an extremely sensitive test and a really, really good test, but it's a little bit more expensive to do and a little bit more technically difficult to do. So because of that, if there's a huge amount of demand, not any old lab can do that. So there are certain tests that are pretty easy to implement, and then you can ramp them up really easily. But because this is a really good test, but one that's a little bit more complex technically, it's only really specialty labs that have the expertise to ramp it up in any kind of responsive way. So the best test for detecting the virus that's around is this PCR test. And that's a great test for determining if someone's had the virus in their nose and has it now, and correlates nicely with people who have symptoms. The problem with a test that's looking at nucleic acids for detection is that you're immune system does a good job of killing off the virus. And then it takes a little while to sort of mop up the mess, the inflammation and things like that. So often in this super sensitive test, even though there's genetic material left from the virus, there isn't actually virus that's infectious. So viruses are very sloppy. So only 10 or 20% of the genetic material they make actually turns into a real viable virus. So then you have a problem with COVID, where the virus probably starts shedding just as you're about to become symptomatic, so probably the day before, and then you shed the virus for quite a long time. You're probably only really infectious in the day or two before you develop symptoms, and then probably about another week, 8 or 9 days afterwards. But your PCR test can be positive for a really long time. So then, of course, people get very concerned. Is that virus? Are they infectious? Things like that. And so that is a cause of a great deal of confusion. And then there's the serology test. So the serology is an antibody test, and it's your body's recognizing that the virus has come in and is developing an immune response. So the serology is an indirect test showing that your body has responded to the virus. And the good news is it looks like most people do get these antibodies to the virus, but they usually don't come up until a couple of weeks after you've been initially exposed. So then, of course, there's a lot of confusion as to which is the better test. Do you want the one that shows you've had it at all? Do you want the one that shows that the virus might be there? And then there's, as our knowledge evolves, we initially weren't sure if a positive PCR test meant that someone was infectious. So of course we were very conservative and said, well, anyone who's better has to have a negative PCR test. And so then, of course, that's even confusing for wait a minute, the CDC told me 3 weeks ago that I had to have a negative test, and now it's okay, I don't have to test anymore. And so this creates a lot of confusion. And then, of course, among the lay people who aren't as medically sophisticated as we are, it creates even more confusion. So that's a little bit longer. So basically, the PCR test is a complex, very sensitive test that detects both dead virus and live virus. And then the serology test comes up later and is usually a surrogate for immunity, but it comes up later.
Okay, how about the point of care testing? What method does that use? How sensitive is it? And does it play a part?
Okay, so it depends on what kind of point of care testing you're talking about. So there's the point of care testing that is like a nucleic acid, the one, the Abbott test, and that test is not as good as the fancy PCR test, but is but it's based on that same sensitive nucleic acid testing thing. So that's the ID now that is used, and that's a pretty good test, but it doesn't detect everything. So it's not the most sensitive test, but it is point of care. And then there's an antigen point of care, and people are familiar with these antigen tests because in flu season, a lot of times those doctors' offices can implement those as rapid testing. So those are also pretty good tests, but they tend to be less sensitive and only detect, the people who have a lot of virus. So that's useful, but in a situation where we're not sure what's going on as far as how infectious people are, that may or may not be the appropriate test. Now, we may find out later that it's only the people who have a huge amount of virus, like the antigen test, are really the ones that we worry about. But our information now, since this is a new virus, is a little imperfect. Mm-hmm. So I think a lot of people are using the antigen test for screening because it is much simpler.
Okay. Surrounding that question of testing, say someone, and this is something that doctors see every day or ask about every day, just want to see if things have changed. Someone is exposed to someone who had COVID-19 and that person was symptomatic. But and it was close contact. But this person, the patient is not symptomatic. They've gone to get a test somewhere. How important it is for them to self-quarantine until their result comes back, and then how long do they self-quarantine? Some results are taking 10 to 14 days.
Well, I've actually encountered that among friends and colleagues, and I think this is such a infectious virus, and also often the person who's the index person doesn't get that sick, but someone in their close. I usually choose the conservative course, say everyone should self-isolate, and that they should self-isolate for the entire period, not only for themselves, but for everyone surrounding them. I mean, I think if you're a clinician in the community, you've known cases where a young teenager or 20-something got it, they did fine, and then they gave it to their grandparent or something like that because, you know, families are close. And then the index patient was fine, but the consequences were devastating for the family. So because of those consequences for those who are vulnerable, I tell people, you know, obviously right now, I think you should be wearing a mask no matter what, but also do the self-quarantine, particularly to.
Okay.
Mike, I would add that the key there is the exposure. The known exposure really, to me, changes that whole equation. We're testing a lot of the long-term care workers routinely, surveillance, and they will continue to work pending the result. But someone who has had a known close exposure and they get tested, that's a pretty high concern for me that they could be contagious, and that's the whole point now, to get them to break the chain, as they say.
Mm-hmm. Okay. Along the same line of testing, but also to help us in a practical sense, whether we're employers with employees, whether we are employees ourselves, or whether we're giving advice to people, is this returning to work information. You know, there's some companies out there that are requiring people to test negative again before they return to work. But Dr. Kim, with what you just said, that some people can be infectious free, but still have a positive test because the dead tissue that still contains the RNA in it, they're not really contagious anymore. So what is the right thing to tell people about returning to work? Number one, if they've tested positive and had symptoms, or if they've tested positive and were asymptomatic. Either way. Anybody want to answer that?
I mean, I can. It actually just changed as of Friday, and they really they have de-emphasized the whole testing. In fact, the CDC says you really should not be retested within 3 months. Number one.
Okay.
As far as it relates to the return to work, they call it the non-testing or the symptom or time-based. If you have symptoms, then you're no longer contagious 10 days after the onset of symptoms, as long as you have no fevers and you're improving. You don't have to be completely well for 24 hours.
No fever for 24, okay.
And that's a big step. It used to be 72 hours. And so I think, you know, they really are, as we learn more, we can feel more comfortable as we relax that. If you have not had any symptoms, but were tested, and you continue without symptoms, then you are released, if you will, or cleared to go back to work 10 days after the test
was done.
Correct. And this is very important because they've even really loosened up the criteria as it works even in the healthcare setting. And previously healthcare, the hospitals and others had already, you know, were using the non-testing based anyway, but now the CDC has supported it. And finally, even ACA with the long-term care has allowed the non-testing. You don't have to have a double negative for a positive person to go back to the long-term care. So all of those, I think, have demonstrated that they feel comfortable that that contagious period is defined by that. There are some exceptions about immunocompromised, and I know, Kami, there's a protocol at Tampa General that y'all follow that defines those types of exceptions where you would perhaps want to extend that criteria, that duration.
Okay, thank you. There were a few questions that they would like your opinion. Anybody is welcome to answer this question about the idea of herd immunity, sort of like what the country of Sweden allowed to occur. What was that outcome like? Is it a good idea, etc.? Anybody want to help us with that question?
Charlie, do you want to go with that one?
Yeah, a nice uncontroversial one. So, so first of all, you know, the Swedish experiment was a bold one. And the idea was to protect the older folks and more vulnerable folks, let younger people get infected. About halfway through it, they decided it wasn't such a good idea because their mortality rates were substantially higher than their neighboring Nordic countries, Denmark, Norway, and Finland. And they're kind of caught in between. I don't think they're yet at herd immunity. The last time I checked was about a month ago. I think they were at 25% immune status. Maybe John or Kami or Doug know better. The problem, the kind of twofold problem is we don't know the real number of cases. There has been wildly discordant estimates of the number of asymptomatic patients. The CDC says it might be anywhere from 2 to 10-fold the number of cases. Well, if that were true in Florida, we're still a very long way from herd immunity. I mean, even if you have 400,000 cases and you're up by 10-fold, that means 4 million out of 21 million, and you don't get herd immunity until you're somewhere between 60 and 80%. So do we really want to lose that number of folks that we'll have to lose to get to herd immunity? I don't think so. So I think the best solution ultimately is a vaccine. You know, the dilemma is we kept talking about flattening the curve. Well, that's literally what we're trying to do, is to flatten the curve. That doesn't mean the curve disappears. It means we've flattened it and it extends out to the right. And I think that's what we're beginning to see. And as New York and New Jersey and Connecticut begin to reopen, they're beginning to see recrudescences of the virus, just as you'd expect, unless you stay shut down and you're willing to bear the economic consequences of that, which I don't really think we're ready for, and very few politicians are going to be willing to do. You're going to see this continuous plateau of cases, and Doug's pointed out that we're starting to drop in terms of test positive and total numbers of new cases, particularly in Hillsborough. The number of hospitalizations, all good, but it's extending out into the many months. So yeah, I don't think we're anywhere near herd immunity. I've seen some of the more speculative, maybe crazy websites talking about, you know, that we're very close and it's going to happen at any moment. And another theory is that there's a lot of T-cell immunity, and I don't buy any of that. And Kami can talk to you about our serological studies of our own providers, but the bottom line was they were completely in line with the number of known cases. It wasn't any wildly discordant number. About the seroprevalence was about 8 weeks ago, was about 4 per thousand. God knows what it is now, but that's about what we figured the community-acquired cases were, including asymptomatic patients. So I don't think we're anywhere near herd immunity. I'd be really interested to know what the three real experts have to say.
Well, I agree, Charlie, that, you know, I think there's just too little that's known generally for herd immunity, which is basically means there's enough of the population that is protected that having infectious virus in the community, there are too many people who are immune, so therefore the virus can't be passed along. And I think that is dangerous because really vulnerable people who could die. There also are potentially very, very serious medical consequences, even if you do live. And then I think there's a basic assumption that everyone, once they've had it, is going to be immune forever. And I don't think we know that. So I think there's just a lot we don't know. And so to me, it's like playing Russian roulette. So I wouldn't do it.
Okay. A comment was made about vaccines, and I'd like to bring that topic up to the panel. Dr. Kim, I think you might work in research in this area or know what research is being done throughout the United States or the world. Where are we on vaccines? How close do you think we are? And then Dr. Holt, if you could maybe follow up with that by beginning the discussion on if and when we get a vaccine, when we get a vaccine, is there a public health strategy to say who gets it first type of a thing? Okay, Dr. Kim?
So the vaccine stuff this is where it's pretty amazing because, if you're in this basic science world, it's 2 to 10 years, right? And what's really, really amazing is that this COVID really, international knowledge about that began, earlier this year. I mean, I technically began in December, but people really appreciating that it was a big deal is just relatively recent. And then in the lay press, there's at least 3 potential candidates for a vaccine. And this is where, the background of the scientific community is very, very important. As John alluded to, SARS-CoV-1, there are a lot of people who put a lot of research into that virus, and it turns out that there's enough in common that people could jump on that and sort of identify antigens that would be potential components of a vaccine. And then also all the efforts to make an HIV vaccine and other of these vaccines, we're taking advantage of that. So it looks like there are various approaches using sort of a combination virus or using proteins or using RNA, incorporating various antigens. The one that's gotten the most prominence is this spike protein that's important for entry of the virus into host cells. And so there's at least 3 companies that have vaccines that at least look safe and generate antibodies. So that's actually very, very promising. And I think all of those companies have gotten a lot of backing from their governments. And so, Moderna is entering phase 3 studies. Some of the Oxford vaccines, are entering studies. I think there's other drug companies that are just behind them using sort of iterations of the same approach. So a lot of vaccines fail, but I have to say it looks a lot more hopeful than I would have thought if you'd asked me 3 months ago. And I think this is where the governments and industry working together with the scientific community, is actually pretty impressive. So, we don't know, but I think it actually looks, pretty good right now.
Does it look pretty good to have something in how long a time from now?
Well, I guess the vaccine people are saying, that it could be in phase 3. In other words, to see if it really works, by the fall. So I would think by the spring, we would actually know if something works. Then you've got to ramp it up. So that's if it works. If it doesn't work, then, could be longer. But the thing is, have anything like that in less than a year is astonishing and amazing.
First ever, yes.
It sounds really slow and it feels really slow, but as far as scientific advances, that's remarkable.
Great. Yes, Dr. Sinnott?
I was asked the other day, what is the quickest a vaccine has ever been brought to market? It was 1962. It was mumps vaccine. It took them 4 years and 2 months, and they had to fill out a 60-page form for the FDA. Now it's a 700-page form. So it might take a little longer.
Okay. Dr. Holt, any comments on public strategy when the vaccine does come?
Yeah, I think the strategy that I anticipate will be that it'll be focused on healthcare workers, first responders, in the first wave, if you will. I think they're more likely to be accepted by the population, and clearly and strongly encouraged by the environment, the workforce, the employers. And then the next would be our high risk for severe disease, those of our elderly population, and comorbidities. The critical part from a public health standpoint will also be how do we engage our minorities and sometimes our disenfranchised population to make sure that they have full access to it. But the harder thing may be acceptance of it in some of those populations. So I think it's critical early on that we engage the public and the community in those risk groups to be accepting. We're already predicting and anticipating some resistance and like with all vaccines. I do not believe children will be necessarily the early phase, just because I think their risk of disease, but also their transmission isn't a driver. It's very different from the influenza vaccine, where some countries focus on the young. So that's kind of what I anticipate. Welcome to hear any other ideas and concepts in that area.
Of course, at this point, I don't think we know how long the antibodies last in our body after either being infected. And I guess maybe at this time, am I right that we aren't sure how much a vaccine would protect us? Do we know the answer to this question? Are we looking at this vaccine being a yearly thing like the flu, or more prolonged? Do we know that?
I think we have no idea.
No idea. Okay.
Though I think coronaviruses tend to mutate and shift antigenically less than influenza. But at the same time, we don't have a coronavirus vaccine at all. So it's hard to know for sure.
Okay.
Yeah, Michael, to make one point, the Chinese have been trying very hard. We called it SARS-CoV-1, the original SARS, also has a spike protein that binds to the ACE site. They've been trying for 25 years to make a vaccine, and they have not succeeded. The immunity is short-term and not very effective. So I worry a little bit about our vaccine chances, just unless someone comes up with a totally new platform like naked RNA vaccine, or perhaps using a viral vector to carry some of the spike protein into cells so we make antigen all the time ourselves and self-immunize. But it may take a total breakthrough in virology to do that. Charlie, what are your thoughts on that?
I think we have a couple of advantages in that we have some varied approaches to vaccine. We have the traditional vaccine approach of a purified spike protein, nucleocapsid protein. We have the adenoviral approach of an attenuated virus that we can mount a response to. We have the RNA approach, which is the most radical. The questions will be, number one, is the response both T cell and B cell mediated, or is it just B cell mediated? It may be important to have both. The second is that the initial responses to both the Moderna and the NIH nucleic acid vaccine was pretty robust. In the case of the Moderna study, the antibody titers were 3 times the level of convalescent serum. So that's good, especially if that's sufficient. And it suggests that the arc of recovery might be long enough so that a yearly combination of the antigenic drift influenza virus guess and a straightforward repetition of amnestic boost to the coronavirus might be sufficient. So you get your annual flu vaccine, which is a combination of factors. So I'm inclined to think we'll be okay. I think that the response so far, as Kami pointed out, this is unbelievable that there would be this amount of development this fast, and that I saw that I think it was Merck already has 600,000 doses ready, and they're producing like 20,000 a day. So they estimate that they'll have a adequate supply. I think they actually said they'd have 600 million doses available by January 1st. Wow. I mean, that's pretty amazing. And as you were talking, I was daydreaming and I was thinking back to the first grade, and this will tell you how old I am, when we got our polio vaccine. John and maybe Doug will recall these days. And I remember the first year I got a shot, and of course it was a Catholic school, so there was no discussion. Your terror of the nuns was far in excess of your terror of the shot. And the next year we got the Sabine oral vaccine, and they just lined up 1,500 students and they gave them all the shot. No thought of parents, vaccine denying parents. They would have been, sent into the netherworld by the nuns, I suspect. And that was it. We achieved herd immunity within, a year, with every kid in the United States being vaccinated. It was really a remarkable thing. So this is comparable. This will be, if it works, this will be one of the remarkable achievements of modern medicine, I think. And if it doesn't work, we are in a world of hurt.
Okay, Dr. Holt, can you give us up-to-date report on availability of hospital beds here in the county, specifically ICU beds?
Well, yeah, those of us that are involved in the hospital dynamics, really, there is no fixed number of ICU beds. They really expand day to day. So if you look on the website, you may find that the ICU occupancy is north of 90%, but in reality, they can surge that fairly easily. The limiting factor, and I guess actually Dr. Kim would probably be closer to this, has to do more with staffing of late. And behind the scenes, that's what we're working with for the state through the federal government to provide additional nurses and even doctors to some of the healthcare facilities that we work with. So we're in pretty good shape as far as our medical capacity. The throughput is excellent. We've developed several facilities to transfer transition, some of our long-term care and others. So we have a hotel right now that was used for isolation, been underutilized, and we're working with some daycare to see if we can create sort of an outpatient level of home health care in a group setting. So there's really a lot of innovation to keep the hospitals, without being stressed. So, but I know, Kami, you're on the rounds over there, so you probably have a better sense of the real time. Pinellas Pinellas is a little more stressed, but if you look at the average median age of their population, it's close to 48 or so, and ours is like 35. So we're fortunate in that the people getting infected in this county are significantly younger. And I'll stop there.
Any
So I
comment,
think
Dr. Kim?
so I think Doug is You know, this is the advantage that got sort of in a dress rehearsal in March and April, is that we know how to manage the patients much, much better and things like that. And the ICUs can be expanded, and, you know, many of the hospital administrators were very proactive about, you know, ordering ventilators and things like that. But the problem is that, you know, people do get intubated and they do make it off the vents, but they frequently spend a few weeks on the vents. And so what you have is way more people who are spending more time on the ventilators, and then you need that expert staff, the nurses, the respiratory therapists, all these kinds of specialized, skilled, experienced people who can take care of all of them. So, and that's the thing that we're trying to stay ahead of. But it's tough, particularly since, yes, our patients are younger that are hospitalized than they were a couple of months ago, but we still have an ICU entirely filled with ventilated patients that we didn't have any time before. And so if this continues, there will be some concerns about having enough staff. And then also we have wonderful, wonderful staff and nurses, but, you know, they get burnt out doing this nonstop for so many months at such an intense level.
You know, it is remarkable, though, that Hillsborough County's case fatality rate, so the deaths over total cases, has always been much lower than any of the local counties. And at one point, Sarasota was 12%. Hillsborough was never, I think, above 3.1 or 3.2%. We actually dipped down to 0.8% last week, 0.8%. And today I think we were at 1. We've been hovering between 1, 1.1, and 0.9 for about a week. And I just glanced at it this morning, and we were about 1%. So some of that is that we're picking up younger folks. Some of it is that we've ramped up testing in the county dramatically. And we've hit 4,000 tests a day several times, which is more than twice what, well, it's about twice what the Harvard Global Health Institute recommended for containment. Now, we haven't contained it because our case positive rate's too high. But I think it's a combination of, we're picking up younger people, we're picking up asymptomatic folks, we're picking up pre-symptomatic folks, milder infected folks. And we definitely are in better shape in terms of the treatments, remdesivir, dexamethasone, convalescent plasma therapy, better idea of how to vent people, how to avoid ventilation by prone positioning and high flow oxygen. But, you know, it is pretty odd. And I've had several debates on national television about this, and the doom and gloom folks keep saying, well, yes, but pretty soon Florida will be at 10%, just like New York City. And I just debated somebody the other night about this. And I said, well, that may be true. I'm not clairvoyant, but, you know, I have been following it pretty carefully, and this is now week 3. So we should see a big spike if the case fatality rates are anywhere near what the doom and gloom folks say, which is somewhere around 6%, but we're not seeing it. It's about 1%. The whole state, as of last week, the case fatality rate for the state was 1.5%. That's actually dropped threefold in the course of June. So it may be that they're younger, although the age has crept up statewide and been pretty flat around 35 years of age in Hillsborough. But it does make you wonder whether there's also some biological changes going on. There's been an alteration in the genotype of the virus since it started in the country. And we now we have predominantly this G variant, which tends to lead to higher viral loads in the nasopharyngeal tract. And that may be one of the reasons younger folks are getting infected. Maybe they weren't getting infected before. We're saying it's because they're non-compliant, they're all partying, they're all hanging out at pools, and there's 5,000 teenagers there, and that may be true. But I suspect that that's not entirely the case, and it's certainly not been the case in the last couple of weeks, where compliance has improved as a result of the counties and the mayor's decision for mask mandates and so forth. So the other thought I've had, and I've tossed this, John's one of the planet's experts on this, but is it possible that by having earlier higher viral loads in the oral pharynx, nasal pharynx, people aren't mounting an earlier immune response and they're never getting the level of pneumonia that they were getting earlier? So we'll see. I mean, I just find it extremely interesting that the case fatality rate in Florida is low, much lower than in New York, New Jersey, Connecticut, and in Hillsborough it's particularly low. Now, and again, next week I may be eating my words, although hospitalizations are starting to slow down, as Doug pointed out, and cases seem to have peaked and are starting to drop. Case positivity seems to be dropping a little bit, and deaths may be, 3 weeks away. There's going to be a lot of Monday morning quarterbacking about this and what really happened and what really affected some of these epidemiological trends. But I just find that case fatality rate really, really interesting. I'd love to say we have the greatest doctors in Hillsborough County in the United States, which of course we do, but there may be other factors as well. It will be really interesting to see over time if some of these guesses on my part are true.
Well, let's hope so. In just a minute, we're going to be handling the question of the day about school reopening and how to do that appropriately. But before I pose that question, I just want to invite any attendees that have joined us online to feel free to ask some specific questions, which I'll bring up at the end of the next question about schools. And if you haven't done that before, there's an icon at the bottom of your screen that says chat. Press that and a blank screen will come up to the right of your computer or whatever you're joining us with, and you can type in your questions there and send it to panelists. I will read it, and if it's appropriate and we have time, I'll be able to ask panelists individual questions after this. Okay, so we're talking about as a possible lightning here lately here in Hillsborough County of cases and hospitalizations. Just in time now for school to be starting next month. Dr. Sinnott, what are your thoughts on this? I'm sure you get asked this question, you probably personally and professionally. What opinion are you giving?
I think if education is critical, it's what makes America great. It's a necessity. The people working with it are working within a bureaucracy. And we know that bureaucracies are not where you go for creativity. It seems to me that if I were going to, say, design an educational program, we live in Florida. Why not put up open air tents and have people outside and learn? Why stick them in a classroom? They learn just fine in Africa and India, China, other places. They did that with the great influenza and found it had very good results. The second thing you would do is you would cohort the children. And children, by the way, are not especially contagious, especially the under the age of 10. So a group of kids, as long as they stay together, get them outside the building so there's not this insane rush to change classes. Or maybe you would have that group of kids in the same room the whole time. I know actually, Charlie, I don't know if you knew this or not, but in Rhode Island, a group of educators during the great influenza rented barges and taught out on the river. And none of their kids got sick and they didn't. So we have a Hillsborough River, we have barges, certainly a different idea. But the idea of getting them out where there's fresh air, moving air, and not recirculated air is critical. The idea that we're going to have to reshape society. People can't wrap their heads around not going to class. But really, going to class could be easily done outside. The military certainly does it. The police academy does it. They do fine. Secondly, the idea of much smaller classes suggests itself, which would give a better educational experience. And then I think be less risk for the teachers and a better experience for the kids. Instead of 30 in a class, you have, say, 6. Just a few thoughts on that. I would be very hesitant if I had a child about sending them to school in a closed classroom right now, because I don't know what the long-term effects of pediatric infection are. No one does.
Panelists, any other ideas or thoughts on opening the school situation?
Well, I can talk a little bit about the university, which is obviously a slightly different scenario. And I think the general approach that people are using are, number one, we're having a mix of both online and in-person, just like in the medical school, a mix of both online and in-person classes. There is social distancing. There is going to be a mandatory mask policy for the faculty that are older and at risk. They won't be put in harm's way. We're also working with the FDA to try to roll out, and COMI's been involved with this, pool testing, so that we can actually do surveillance of dorms, athletic teams, medical students, using maybe up to 10 individual samples put in a single viral transport media. Probably aren't going to get to 10, but if we could, that would be an incredibly efficient way to surveil big groups of students, because you'd be able to do one test and get 10 people evaluated. And if you have a low prevalence of the disease, most of the tests will come back negative, and you won't have to follow it up with individual diagnostic tests. With working with the FDA, we may be able to do this on the campus, and we can use our research labs. So the turnaround time can be much, much faster than if we send it to Quest, and it's going to take, by the time you get a result, the patient's either in the ICU or completely better. This would be, a day turnaround. So those are some of the strategies we're using at the university level. I think some of them can be applied to the school system as well.
Okay.
I think one of the things that people are talking about is, what are the right conditions? What are the metrics? And as Dr. Lockwood had mentioned, this virus is going to be with us. So, it's not going to go down to the levels that are going to give us a great deal of confidence that there is safety. It's again, Dean Lockwood is a military historian, and it's got, it's like D-Day. You're not going to have the perfect conditions. You're just going to have to launch. But you got to do everything you can to mitigate. You've got to get the teachers need to feel safe. And we're working very much to educate them about what is the risk and what all we're doing about them. So clearly the mask and face shields, I think, are critical. Giving them breaks. Dr. Sinnott mentioned some outdoors. You might not be able to stay out all the time at this stage, but certainly as the weather gets a little more tolerable outside. But even now, get breaks, get out, break, and in small cohorts, bubbles, if you will. The other piece that we're going to have to really figure out and be prepared is, how do you do the investigation, contact tracing, and the determination of, you can open them, but can you keep them open? And what are the definitions about how we will either, target our exposed people to leave, to go home, quarantine? Can we keep it to a class? Do we have to do schools? And so that's one of the things that we've got to use this time prior to the opening to really have a good handle on. And so we along with my panelist colleague, are looking at what's the utility of going in with a positive case and doing some sampling, rapid sampling, maybe with the antigen and other types of testing. It'll give us some information. And I think it's reassuring to the public and the parents that we've done something. So I don't know if it's going to be the answer, but now is the time we've got to do what we can to provide some confidence that we are making every effort for their safety.
Okay, all good points. And I think as a parent, I think you have to think about different considerations on whether you have like a 7-year-old child and how are they going to be able to be compliant versus say a 15-year-old son or daughter versus someone going to college. There's differences in all those type of settings that you just have to take each case or each individual at a time. Along the lines of schools, and here's a question that came in. I'm going to throw this out to anybody who wants to answer it. It says many kids camps and or schools are or will be requiring a negative test in order to come to the camp or back to school. But some results are taking over 10 days. So that's a huge problem moving forward as we face going to class. Please comment on the need for this before going to school, returning to school.
I do not believe it is needed to be coming back to school. I know that as Charlie talked about, once you're there, perhaps doing some surveillance testing makes much better sense because, again, it's a point in time, and all you're left with is an information that is already old as far as its true risk and whether it's going to. You're not going to keep campuses. You're not going to keep schools completely free of the virus. That's just so. I do not agree with that strategy, and I would not support it.
We just don't have the capacity to be able to do it. Just imagine hundreds of thousands of kids getting tested, and their teachers and the staff and the the house cleaners, and I mean school bus drivers and so forth. By the time you got results, they would either be better or they'd be in the ICU if they were older. So I agree with Doug. I think surveillance is very useful, and making sure that they've been quarantined before they start school and are afebrile, and then doing the other checks that we can do as they enter, I think are very reasonable things. You know, in an ideal world with unlimited testing and a turnaround time of 4 hours, sure, yeah. I mean, you know, I think it's is it Major League Baseball that's testing everybody every day? Well, yeah, that'd be great. Not going to happen.
Okay. Another question from the viewers is that right now the United States consists approximately of 1/4 of the COVID cases worldwide. Is that because we're just testing a lot more people, or is it because we're doing a worse job in containing the disease, or a combination of the two?
Well, you know, to be fair, testing, we do have extraordinary levels of testing now. I mean, that is indisputable. And when we had a 5% test positive rate, I think you could blame testing for a lot of it. And we were picking up the asymptomatic folks, the mildly affected folks, pre-symptomatic folks. But when you have a consistent test positive rate of between 12 and 15%, Doug, is that about right? Then we're not testing enough, and you can't blame the increase in testing. This is clearly spread, and it obviously correlated with the opening of the economy. So, you know, and particularly among young folks. Now that could be biological, but I think non-compliance is a big factor. But I don't think you can blame testing.
Okay. Any, is there any parting thoughts for any of the panelists would like to leave with our members tonight?
Wear a mask outside. Try to be a role model for your patients and your family and everybody out there that it's really critical. It's the only tool we really have. I mean, obviously social distancing is important. It's another tool, but that's it.
Yeah. Not much has changed along that regard in the last 2 months. We have a little bit more data. We have some history. We have some knowledge in some few areas, and we have some advances in testing and soon to be vaccines. But we still have what are on some billboards, and we'll call them the 4 C's. Still clean your hands often, still cover your face with a mask or better, still avoid close contact, and still avoid large crowds. That's sort of the topic that we ended up last session, if I remember right. But it's the only thing we have right now, and it's important that we as physicians emulate that to the people in our contact and people in our influence, and that we teach that to our patients also. I want to thank you.
Can I
Yes,
just
Dr.
say one
Michael.
other thing?
Yes.
So when this all started, way back when, John's not going to remember this, but when this all started way back when, I said, John, when do you think the peak of viral activity will occur in Tampa? And he said August 1st. So either he's prescient or I don't know what he was smoking, but he was spot on.
Thank you.
Any comments? Okay. Thank you. I want to thank for all the panelists for joining us this evening. Hopefully we can get together again in the near future if more information becomes available and this continues to be a benefit to our members. I wish everyone to have a good night. Thank you very much.
Thank you very much.
Thank you.